So hello friends, today I'll be talking on this new article that came, which is the use of Barcitinib and Remdesivir. So this particular talk I'm giving it on 16 December. So as you see, this particular article came on 11th December 2020. The title is Barcitinib plus Remdesivir for hospitalized adults with COVID-19. So this is a double-blind randomized controlled trial. So the main purpose of this trial was to compare one group which was given remdesivir 200 mg once a day, followed by 100 mg for 9 days, which is the standard dose that we would give. And this was compared with another group which got remdesivir along with barcitinib. So the primary outcome of this study was to look at the time to recovery, which is the typical sort of a primary outcome that has been looked in ACT study and in Solidarity trial. So it is to look at time to recovery on a 8-category ordinal scale. So and if you see all the COVID studies with remdesivir or steroids, they have always looked into this ordinal scale and try to see whether the outcomes were meaningful at the end of therapy. So if you need to just recall what is ordinal scale, so it is a scale on 8 where the category 1 is where patient is not hospitalized and there's no limitation of activity, and the category 2 is where patient is not hospitalized but there may be limitation of activity and home oxygen. Category 3 is where patient is hospitalized but not needing oxygen or not ongoing treatment. Category 4 is patient is hospitalized and no oxygen but there is some ongoing treatment. But what is of most relevant to us, which most studies have emphasized, is to look at category 5 where patient is hospitalized and is on supplemental oxygen. So our attention or our thought process should be mainly on the ordinal scale of 5 to maybe 7, because the 6 ordinal scale is where they're hospitalized and they're on NIV and HFNO, and ordinal scale of 7 is where they're intubated and mechanically ventilated. So 5 to 7, if you remember, that is most pertinent to our intensive care doctors or listeners, and these are the type of patients which we would be typically dealing with, and we are more interested in looking at outcome in these categories. So the secondary outcome of this study was to look at day 15 clinical improvement. So these were the outcomes they have looked at. So now we need to understand what is barcitinib. So barcitinib is a JAK inhibitor or Janus kinase inhibitor. So it inhibits two type of Janus kinase, JAK1 and JAK2. And by inhibiting this Janus kinase inhibitor, JAK1 and JAK2, it inhibits the intracellular sort of a activation which is mediated by interleukin 2, interleukin 6, interferon gamma, and granulocyte colony stimulating factor. So there is this intracellular signaling pathways that are mediated by these cytokines, and by inhibition of JAK1 and JAK2, this intracellular signaling is inhibited, which are mediated by these interleukin 2, interleukin 6. So that is the way barcitinib is proposed to act in COVID. And along with this, barcitinib prevents the entry of coronavirus into the cell by impairing the AP2 associated protein kinase. So this is another mechanism where barcitinib inhibits the entry of SARS-2 virus into the cell by impairing AP2 related protein kinase. And it is also shown barcitinib improves the lymphocyte count. So we understand that in COVID-19 there is significant lymphopenia, which is an important prognostic marker for bad outcome. So barcitinib is known to increase the lymphocyte count. So the pretext or the preamble or the premise for this study is there have been 3 case series, one from US, one from Italy, and one from Spain, where barcitinib has shown to improve oxygenation in patients with COVID and reduce the inflammatory markers. So this is the premise for doing this randomized controlled trial. So how did they go about doing this study? So like ACT study or Solidarity study, they had multiple sites. It was a multicentric study. It was a multicentric study. So with 67 trial sites. And as you see, like in ACT or like in Solidarity, 55 sites, predominant sites were present in US. followed by 4 sites that was present in Singapore, 2 sites were present in South Korea, 2 sites were present in Mexico, and 1 site each in Denmark and UK, and 1 site each in Japan and Spain. So there were 67 trial sites across the countries. And the study was conducted between 8th May to 1st July 2020. And as I said, it was to compare Remdesivir in one group versus another group which got Remdesivir with Barcitinib. So what is the dose that the patients with Barcitinib group got? So the dosage of Barcitinib was 4 mg given as 2 mg twice a day for 14 days. If patient had estimated GFR of less than 60 ml per minute, they got 2 mg once a day of Barcitinib. So in the results, the mean age of the patients in this study was 55.4 years, and 63.1% of the patients were males. And we have seen this even in the ACT study or Solidarity trial. The major percentage of the gender was in males, and most of the studies have shown the distribution in males is around 60 to 65%. And I think this is an important limitation of this study. So now we clearly understand in the patients with ordinal scale of 5 or 6, which means patients who are on oxygen or who are on NIV and HFNSO, these are the patients who are going to benefit with the use of steroids based on the recovery trial. But in this particular study, steroids was not used as a standard of care for patients who are in ordinal scale of 5 and above. So I think this becomes a very important limitation. So basically the way you would look at this study is Barcitinib is looked at as a replacement for corticosteroids. I think that is an important point every listener should bear in mind. So here corticosteroids was not given as a standard of care in patients who are on oxygen or higher support, and they looked at the efficacy of Barcitinib. So that is a very important limitation. But there was group of patients which did end up getting steroids who were needing steroids for other clinical conditions, that they would have been on steroids for other autoimmune condition, or if they were asthmatics or COPDs who needed steroids. So these were the patient groups which anyway got steroids for indication other than COVID. So that is an important limitation or point that everyone should bear in mind about this particular study. so, so they have looked at the number of patients in the ordinal scale of 4 and 5. So as I said, for listeners, ordinal scale of 5 is important, which is patients who are hospitalized and are needing oxygen. So 4 and 5 constituted 706 patients, and patients who are on ordinal scale of 6 and 7, which means who needed NIV or HFNSO or who needed intubation mechanical ventilation, was 327 patients. So this was the summary result of the patients. So they had 1033 patients. 515 patients were in Remdesivir and Barcitinib group and 518 were in Remdesivir group. So the time to recovery was 7 days in Remdesivir group, and it was 8 days in Remdesivir group. So there was a 1 day difference between the combination. We'll call Remdesivir and Barcitinib as a combination group, and the recovery rate ratio was 1.16, and that was statistically significant. And the time to recovery in patients who were needing HFNC and NIV also was significantly less in the combination group. It was 10 days compared to 18 days in the Remdesivir group. And if you see this confidence interval, this was statistically significant. So this is an important message this study is sending, that in patients who are needing oxygen or higher support like HFNC or NIV, the combination therapy improved the recovery time. So it enhanced the recovery time. And what about improvement in the clinical status at day 15? It was found to be 30% higher in the combination group, but it did not achieve statistical significance. And 28-day mortality, it appeared less in the combination group as compared to the Remdesivir, but again this did not achieve statistical significance. And interestingly, this study showed the serious adverse events were significantly less in the combination group as compared to the Remdesivir group, and that was statistically significant. And even they found, surprisingly, the risk of new infection was less in the combination group as compared to the Remdesivir group, and that was also significant. So that was an interesting finding. So the key points of the primary outcome that they found statistically significant was the time to recovery in the whole overall group of patients, and the time to recovery in patients who are on HFNC and who are on NIV, and the serious adverse events were significantly less and new infections were less. So how about ordinal scale of 4 and 5? They looked at recovery rate ratio. It was 0.88, and you see that was not significant. And patients who are on intubation and mechanical ventilation or ECMO, the recovery rate ratio was 1.08. That was also not statistically significant. And they looked at patients who got steroids, and they saw whether the recovery rate ratio was significant. Even that was not found to be significant, which is very surprising, that they studied the patients who got steroids for reasons other than COVID, and they found that the recovery rate ratio was not statistically significant. So then the study also looked at some of the key secondary outcomes. So we saw in the patients with ordinal scale of 4 and 5, it did not achieve statistically significance. But when they looked into patients with ordinal scale of 5 and 6, and they looked at the day 15 clinical improvement, and so they found there was a statistically significant improvement in the clinical improvement at day 15 in patients who were needing oxygen and higher. And they looked at median duration for one ordinal scale improvement, which means to say, if we are treating a patient with ordinal scale of 5 or 6 and they get better and move to the ordinal scale of 5 and 4, so that we call it as a median duration taken for improvement in one ordinal scale. It was 6 days in the combination group compared to 8 days in the Remdesivir group, and that was also statistically significant. And the number of patients who went on to needing new oxygen after initiation of therapy was, as you see, the percentage was significantly less in the combination group as compared to the Remdesivir group, and that was also statistically significant. And they looked at the percentage of patients who went on to needing new mechanical ventilation, intubation and mechanical ventilation and ECMO. That also was significantly less in the combination group as compared to the Remdesivir group. So all these secondary outcome indices that they looked into, which was mainly to in the ordinal scale of 5 and 6, and patient going on to needing new oxygenation or patient going on to needing intubation and mechanical, was significantly less in the Barcitinib group with Remdesivir compared to the only Remdesivir group. So this is an important findings they found as a secondary outcome results. So these were the Kaplan-Meier curves, which are a pictorial representation of the recovery patterns. So as you see, overall, they found a statistically significant improvement in the time to improvement was significantly better in the combination group as compared to only the Remdesivir group. That was significant in the overall group. And then this they looked at in the patients with ordinal scale of 5. There also they found statistically significant time to recovery was better in the combination group. So the shaded part is the confidence interval that is indicated in the KM curves. And they looked at ordinal scale of 6. Again, you see there it achieved statistical significance in time to recovery in patients who are needing NIV or HFNC. So what about mortality indices? So obviously we're all interested whether this combination made any difference to mortality. Unfortunately, none of the mortality endpoints attained statistical significance. So they looked at mortality in patients with ordinal scale of 5, which was 1.9% in the combination group compared to 4.7% in the Remdesivir, but it did not achieve statistical significance. They looked at in patients with ordinal scale of 6. Although it appears there is signal towards reducing mortality, which was 7.5% in the combination. In Remdesivir, it was 12.9%. Again, it did not achieve statistical significance. So they looked at 14-day mortality. It was 1.6% in the combination and 3%. And again, this did not achieve statistical significance. So none of the mortality endpoints that they looked at in patients who were needing oxygen or in group of patients who were needing NIV, HFNC, and 14-day mortality. Unfortunately, this combination of Remdesivir and Barcitinib did not achieve statistically significant reduction in mortality. I think that is also a very important message this study conveys. And how about progression of these patients to death or needing NIV or intubation or mechanical? They looked at all these three as a composite endpoints. That progression was found to be significantly less in the combination group as compared to the Remdesivir group, and that was statistically significant. How about the patients who went on mechanical ventilation and who were on ECMO? They looked at the duration, and they found there was a significantly reduced duration of patients needing intubation, mechanical ventilation or ECMO in the combination group as compared to the Remdesivir, and this achieved statistical significance. So again, you see that it did have various endpoints where it did achieve statistical significance. So mortality, it did not achieve statistical significance, but it did achieve statistical significance in some of the secondary endpoints, which is patients in the ordinal scale of 5, time to recovery, and ordinal scale of 6, it showed improvement, and it did show improvement in in patients going on to needing new oxygen or patients going on to needing new mechanical ventilation or ECMO. So what about safety? So they did look at the risk of infection in a subgroup analysis where they looked at a group of patients who were receiving glucocorticoids. 223 were receiving glucocorticoids and 793 were not receiving glucocorticoids, and they found the risk of infection was significantly high in the group which was receiving glucocorticoids when compared to the group which was not receiving glucocorticoids. So this may be an important message currently in this situation where there is increasing use of steroids as a standard of care for all the patients with COVID who are needing oxygen or higher support. So this may be an important statement. The study is telling that the risk of infection is much higher in patients who require steroids. So coming to the end of this conclusion, so how much ever you read this study, the key take home points of this study is Remdesivir with Barcitinib when compared alone with Remdesivir was found to be superior in reducing the time to clinical recovery overall, and it did accelerates the clinical recovery in patients who were on HFNC or who were on NIV, which is an important group of patients, and this is the group of patients where we wish to see improvement in the outcomes or improvement in or enhanced improvement in a shorter period of time, and that was indicated in this particular group. And most significantly, the side effects or the serious adverse events were significantly less in the combination group, and these were some of the important secondary outcomes that were found to be significant in patients with ordinal scale of 5 and 6. Day 15 clinical improvement achieved statistical significance in combination therapy, and the median duration of one ordinal scale improvement also happened better in the combination therapy, and patients going on to needing new oxygen was significantly less in combination therapy, and the patients who go on to getting intubated or who is going on to needing ECMO also was found to be significantly less in the combination therapy. So this is the summary point of this particular uh, important study. So it is important that we look into this paper with a little bit of attention, and I urge the listeners to go through this paper in detail, and most of the key essence or the quintessential points I have covered in this particular narrative. So thank you very much. So I would end my talk with this important quote by Ralph Waldo Emerson: sow a thought and you reap an action, sow an act and you reap a habit, sow a habit and you reap a character, sow a character and you reap a destiny. Thank you all. So if you wish to rehear to this lecture, you can visit my website www.drpradeeprangappa.com, and you can rehear to gain clarity and insights. Thank you all.